And so with that, I'm going to turn it over to Michael, who is the Deputy Policy Director and one of the key partners that the ACHs have with the Healthcare Authority. He has been just awesome to work with over the last, I'm in a time warp, I don't know. I will say over the last little bit, as we have maneuvered our way through years 4 and 5 of the Medicaid waiver and COVID and what comes next. We have been working the 9 ACHs and the Healthcare Authority in what just feels like new levels of partnership over the last year, as we all share a goal of continuing this transformation work longer term and really seeing where we've had good success in some of the early 1115 waiver work and where there is more work to do. So this is a presentation that they shared with the ACH directors. And I will just say, I was delighted beyond belief at the thoughtfulness of how they're thinking about the renewal, as well as the sort of embedded role for both regional voice and the regional sort of influence and the role of the ACH, while balancing out that not all ACHs are the same, and that different regions have different focus and capacity and so forth. So I think they've just done a fantastic job. And it felt really important to me that you all heard this as we are thinking about our next sort of 3 to 5 year trajectory, because I think there's some really important parts that will aid, or at least fingers crossed that it all goes through in the way we imagined it would, from a sustainability portion of the work we've started and what that looks like, and that we would want to use that vision of the renewal in our, how we would spend our next, $30 or $35 million that we still have to allocate out of the current waiver. So with that, I'm going to introduce Michael to you and let him walk his way through this. Michael, we tend to let folks kind of give their presentation and then do questions at the end, if that works for you. If it's easier for people to go, whoa, in the middle, we could also do that. Your call, presenter's call.
Allison, thank you. And thank you for the introduction. Pam, members of the board, this is a privilege to be here to talk with you about this. I think it might work out pretty well, Allison, to try to go through the presentation. The one caveat I would say is that there is, unfortunately, terminology and acronyms in here. Anytime we are dealing with federal Centers for Medicare and Medicaid Services, it is nearly impossible to get rid of those. We attempt to. So all that I would say, if there is an acronym or some term that is just hanging somebody up and it would like some clarification before we go on, please do ask. It's I just apologize up front for the kind of Medicaid minutia that we have to get into to fully have a conversation. But with that, we have been working very carefully with our internal people at the Healthcare Authority and with the ACHs. And so the ACHs, in the biggest possible way, really have one foot internally with us and one foot externally, because we really view you as sort of internal partners as we put together the idea of a renewal. And so we can't do this without you. So for today's presentation, my 2 goals are to introduce this to you, but also to get some input, because we are still developing this and it is ripe for input. And then you'll see some timelines in here. You'll see where we'll have to start making some decisions and then go forward with those decisions. So as we go forward with the deck, about 20 slides, it divides in half with where we've been. And I'll try and go through that fairly rapidly, but again, hold me up if you need to. And then we'd like to concentrate on the work we're going to do with you in the renewal. And I think the renewal is large. Your piece in it is one of the largest portions of it, and it's probably best that we talk about the ACH development of the renewal. There's other pieces if you want to get into those, but they might be quite tangential for this group. And then just as an introduction, we are with the Medicaid program at the Healthcare Authority, we are allowed to put forward waivers to do new things, to try demonstrations and to see if those programs work. And then we try to move them into the Medicaid system. But usually with a big renewal, with a big, waiver, we are allowed to do one big renewal. So we'll talk a little bit more about that as we go forward, but that's where we're at in the project. So we can go to the next slide. And so again, we'll talk about how we got to where we are with the background here, the evolution of our current activities, and the arrow there points to what we would particularly like to talk with you about today. And then of course, give you a sense of timeline and key dates coming up. So then going forward, next slide, as I said, we can put forward for a thing called a Section 1115 waiver from Centers for Medicare and Medicaid Services. And of course, Section 1115 just named after the section of the law that allows for this. But a waiver is perfectly named. It allows us to have flexibilities and funding to do some things that we would like to try, but don't really quite fit into the Centers for Medicaid and Medicare Services vision of a Medicaid program. They are typically 5 years, and ours runs 2017 through 2021. So as you can see, we're coming to the close of our first 5-year period. And then on the next slide, we're going to talk about those initiatives. We had, of course, by far number one there is our work with the ACHs and the Indian healthcare providers. Out of the 1.5 billion, 1 billion of it was in that bucket for the 5-year period. And we do appreciate the partnership very much. I think one of the biggest things that the value that has been shown is that how much we can get done by having flexibility at the local level. The other 4 long-term services and supports are done with our partners over at the Department of Social and Health Services, and MAC stands for Medicaid Alternative Care, and TSOA stands for Tailored Supports for Older Adults. I have a bit of a problem with that because older is defined as 55 and older, and I don't think of myself as older yet, but that is the way it is. But it's entirely about helping people age within the environment they're in and try to forestall going into institutional care as long as possible. And that's turning out to be quite a good result. And then foundational community supports, we're back into the healthcare authority again. And this is about providing stable housing and employment support. So even though we don't provide rental subsidies or we don't help people with their salaries, this is a service that helps people into housing and into employment. Just a side note that has been evaluated so far and is one of our first really big successes that we've been able to validate. The next 2 items are all about supporting that vision of helping with substance use disorder and mental health services. You know, we lump those together and call them behavioral health. And again, try to provide services that build better capacity within the institutional framework in this particular case, and then make sure that we get federal funding to do that. At the same time, we're trying to build out our capacity in the community and home support. So that's the big picture we started with, and that was our 5 initiatives in our 5 years. And then I think on our next slide, we're going to get into the 1 year. Well, first of all, we're going to talk about why we have the 1-year extension. Let me just wrap this up very quickly with COVID-19. We could not have expected a better response from the ACHs. I think it was very fortunate that we were in our 4th year of implementation because ACHs, I think, had their footing. And the participation in the community all the way from, continuing to battle the problems with the opioid crisis, bringing food to people, just the information about COVID-19 in the early days, even to providers, was amazing, as well as the distribution of over 4 million pieces of personal protective gear. It was just a wonderful response, but it did delay the implementation. And so the next slide, what we did is talk to CMS about doing a 1-year extension. So this was rare. We used the term extension just to set it aside from the term renewal. But what typically CMS won't allow us to say, hey, we're having a good 5 years. We want to do all the same things for 1 more year, except that all of us states that had these big waivers were permitted to do that because they realized that, first of all, we needed to keep doing the same thing. We didn't know how long this COVID-19 pandemic was going to last, so good call on CMS's part. And also we had to do some preparation for what Allison was talking about as she was introducing this, the sustainability that we're still working on with ACHs and MCOs and other partners. And we also added a lot of those other programs late. They were not there in 2017, and we just need time for them to mature so that we can see how they work. So for the purposes of this presentation, as long as nobody has a direct link to CMS, let's just consider this extension approved. Because the rest of the presentation doesn't make sense. But CMS has not yet approved the extension. They are approving extensions at the last possible minute for other states, and we expect them to do the same with us. We have very good relationships with CMS because of the wonderful people that I work with. And we are not hearing anything negative from CMS about this. So we do expect that the year of 2022 will be our 6th year of the MTP waiver. So just think of that as part of the original MTP waiver, Medicaid Transformation Project waiver is what we call it, MTP waiver. And we will just continue the same work with you for one more year, except that we want to use that bridge year to get into the renewal, which we'll talk about here in a few slides. So on the next slide, please, I think we're going to go to a timeline here. There we are. Yep. So there we are. That's the July 2021 was what I was talking about at the start. A lot of discussions and research and a lot of discussions with ACHs and also our internal experts and leadership. And then, of course, much more partner and tribal engagement now in August and September, and we need to continue some of these refinements. So that's where we are right now, which is why, introducing it to you and getting some input is so important. And then right around October, Allison, this is a key date for you and your peers, but we will need to say, okay, we're there because we have to write these things, and CMS expects a substantial document from us. These are usually 200 plus pages. There's a lot of description. We have to make the case. And so this is our case to say, we want to continue having hundreds of millions of dollars of federal money coming into the state of Washington for 5 more years, 2023 through 2027. So as you can imagine, we have to cut things off and start putting them down in paper. And just so Allison's not nervous, yes, we've already started putting things down in paper, but we have to close it off so we have clarity when we write, and writing's hard enough without clarity. November 2021, we call out because public comment processes and tribal consultation are a requirement. I mean, heck, we do them anyway, but we have to show CMS that we're doing those. And then final refinements always occur right around the end of the year. And then the submission due date is December 31, 2021. So this again is an awkward way that we work with our federal partners, but they want us to submit a big 5-year plan 1 year before we would actually implement it. So what we negotiate quite a bit is how much can we write and tell CMS where we're going. And then I haven't brought up the Washington State Legislature yet, so I'll do that now, but we have to also tell the legislature, because they fund this, they approve the funding as well, where we're going. So the terms that we tend to use all the time is that we need to tell people as well as possible where we're going without putting down the details. And that's what we attempt to do by the end of December, because we know that something this large, CMS will engage with us next year, and they will want to negotiate the pieces with us. And as you negotiate the pieces, the dollars change. And so that's a big thing that we're communicating right now with the Office of Financial Management and our legislative partners as well. So let me go on to the next slide. I think this is where we start to introduce. Now, we're not quite there yet. So on MTP renewal, the expectations that we've worked on, and again, quite closely with ACHs, and of course, being able to talk with boards like yourself and now the managed care organizations, but the expectations are along the lines of initiatives 4 and 5, which were still very new, just being implemented. Really no changes at all, because we just want to let those programs mature. We will have minor tweaks and improvements for the other 2 initiatives that were added after Initiative 1. It is in Initiative 1, that last bullet point there that we do need to make things different. And let me talk a little bit more about that as we get into it, because we have slides that'll help me out a little bit. If we can go on to the next area, the next slide here. So the waiver really, we do have, these are some of the things, if I can skip through these rather quickly because they don't directly impact Initiative 1, but reentry initiatives, again, with the jails and the prisons. And this came thankfully from a bill that we worked on with the legislature. So we have direction there. Continuous enrollment for children. This is simply to say that we would, for children 0 up through 6, we would not continue to evaluate their income, but of course we would, residency and those items if you move out of state, of course, but it's just to allow children to be continuously enrolled. We do have some American Indian, Alaska Native issues that we're working on with payment and self-attestation that I think are rather important. They'll make the program run better. We'd like to, again, this is with Alaska Natives and American Indians, a payment for some additional, what I would call community health aides, as they say there. Again, helping providers and other clinics to provide services. Allison, these are all the things that we do through ACHs, and these are the things that our Office of Tribal Affairs is promoting. They do the same thing similarly with the community. And then with long-term services and supports, our partners with the Department of Social and Health Services over there have come up with 3 very good items, and we want to go forward and see if we can get all of them funded. Presumptive eligibility works well. Coordinated personal care is an efficient method that they've come up with for providing personal care to people. So all of them just really good ideas. And if I could just scoot on by so we can talk more about Initiative 1, which I think is so germane to this particular group. So on the next slide, there we go. We can go on to the next one, please. So here's why, a little preface here is we were implementing Initiative 1, of course, with all of you and the other 8 ACHs through a really wonderful program that CMS allows us to work on. And when they put that program together, they said, you can use this for the first 5 years. But we don't want to continue to do these programs beyond that. So what we said is that's great. We won't continue to do that program, but we do need to continue with some of this work. And by the way, we've got some other ideas that we think even extend the wonderful things we're doing with ACHs and their community partners. And we think we can fund them. We think we can make the case for them. So foremost in that, so I just don't want to skip by that too quickly because, especially Allison, I think you've been around long enough that there was a lot of concern about whether we could continue with Initiative 1, which we call the evolution of it. And we're actually going to start dropping that term because it's so different than what we're doing today that we're going to start calling it the accelerator programs. But we're still trying to crack the same problems. We just want to convince CMS that we've got some better ideas to do it in terms of better ideas on what to do policy-wise, but also on how healthcare authority can work with state partners to get things done. So I hope that's the theme that you hear me talk about for the next 10 slides or so. But the topics right on top are health equity. We need to do a lot more in that area. We need to make sure that some of the great things we're doing reach everybody. We do that quite a bit by another acronym there, social determinants of health, which we now call health-related social supports. And we think we can make some big inroads on that. I think integration of care that we did in the MTP waiver these days was a great start for integrating physical and behavioral health, but we can do a lot more on health equity, and we've got techniques to do it. Workforce. We all know coming out of the pandemic, it just exacerbated the workforce gap that we had. We need to do that across the state. We need to knit it together as a statewide strategy and make sure that people can implement that strategy differently within each community, because even though the problem is big in every community, the problem is different. Third there, behavioral health integration. We still believe that we need to do more physical and behavioral health integration. We need to assess it. And I think there's some ways we can do that. Value-based purchasing, VBP. we do need to come up with some different ways of providing incentives to make sure that we reward what is going on in the communities, or possibly, put out the message there that money could be held back if goals are not met. And again, that's, I think, where we probably will have some better ideas. I thought we did pretty well on it this time, but looking back on it, we feel like we can do a lot better. And actually, that a lot of that was in the ACH area. And then health information technology and health information exchange. A lot of this has to do with a little thing that we keep calling community information exchange. And it's really a way, again, of knitting together the activities that are done by so much of the good work done by community-based organizations, but they're not always knit together digitally, like you see with an EHR on the clinical side. So we believe that there's a lot that we can do to support that going forward. So the development of the initiatives, and then here's, what we do. Please ignore that first bullet, the budget neutrality limitations. I can't ignore it. You can. We are bound. Probably just worth saying, there were limitations that we are bound by. Hopefully, though, they won't truly limit us with the things we want to do. But those are just things that all of us in Olympia have to watch for with our fiscal partners. We are talking about, excuse me, lessons learned from districts. So that was the delivery system reform incentive payment program. That was the program I was talking about, that our federal partners said, you can do this once, but you got to come up with another idea if you want to keep working on health equity and workforce and such. And then, of course, we looked at the Washington landscape. We spend a lot of time looking at California, Oregon, North Carolina, other states that are quite progressive, trying to accomplish some of the same things, and we are ruthless about stealing things from them. And I don't see why not. If they're working in North Carolina, they probably work for communities in our area as well. And then we were developing a thing called the social investment model with the ACHs. We had some small groups there. We want to, again, ruthlessly steal some of the ideas that we are talking about with some of Allison's colleagues. The thing that we won't implement is actually the governance and the funding model, because we believe we'll do that through the accelerator programs, but we do want to steal the ideas on how to implement health-related social supports, health equity, workforce, and those items. So as we go forward, I'll try and expand on some of these items. If we can go to the next slide. So a little bit more level setting here, the 50,000 foot view. Again, the high level strategies will be health equity, health related social supports, and I've neglected to talk about whole person care. Most of that comes through what we started with, integrating physical and behavioral health. Shouldn't have taken me this long to get to that, but implementing whole person care is how we really want to get at health equity and health related social supports, because you cannot successfully do whole person care unless you're achieving health equity and the use of health related social supports. And then when you talk with me and the great people I work with, we talk a lot about flexibilities. And so that's what 1115 gives us. It waives the things that we have to do in the Medicaid arena. If we think we have good ideas, but they're just simply held up by rules, we ask for flexibilities or waivers to do it. There is capacity funding that we have to be aware of. And then we have to be aware of existing payment mechanisms. Again, that's mostly our responsibilities. And then the ACH functions that we think are going to continue to be critical, and why we continue to partner with you and of course work with you on all these. Of course, I think this is your bread and butter things that I think you know really well. It's the community engagement. You know the needs, you know your partners. The neutral convening. This, if I could bold this and highlight it, I would. I think this is the sort of the secret sauce of ACHs. I've only been in this job for 2 years. I did not know what the term meant when I came in. It has complete meaning to me now, and I see how people get things done in that capacity. And then provider supports and technical assistance. And this probably goes back more to the incentives that we were talking about. We do withhold money with MCOs. We try to create carrots and sticks that make sense. It's an extremely difficult thing to do. It's hard to do it correctly every single time. But I think you have to do it. It has to be part of your mechanism. It has to be part of your incentive process. So if we could move to the next slide. So this is the accelerator programs. And what we need to work with ACHs and what we are going to be promoting with CMS a lot is that we have to find some way that we are doing things in a common fashion statewide. And a lot of times, I think we can make more impact and more push if we have statewide goals and strategies. So the real key to this is, how do we work with the ACHs to say, what are these topics? Well, we're getting there. Their health equity, their workforce, again, assessing integrated care and what we can do. So think of statewide accelerator programs as things that we probably have a pretty good sense of what we want to do. We just need to move out and do them. And the key to that, though, is to describe the goals that we want and then leave the flexibilities at the local level so that you can have a spotlight on what you want to do. You have a line of sight, your partners, you know where you can achieve things. And yes, there will always be measurements and metrics. Nobody is free of those anymore, which is a good thing. But we have to put them in place carefully so that we're measuring the right things. And then the idea being that we have common goals, we have flexibilities at the local level to achieve those goals, and then we measure them throughout the time, and then we adjust as we go, because measurements are not just there to measure and look at things and then point your thumb up or down. It's actually to learn from things and then move forward. So we hope that we would have a lot of sharing across regions as we do these things, but of course always maintaining that flexibility at the local level. Regional accelerator programs is where we would probably say we want to try things. We have a pretty good sense of what'll work. Maybe no one's done it yet. And then maybe we want to try them someplace, maybe in a few ACHs knitting together to do something, or maybe a couple ACHs doing it one way, a couple doing it another way. And then try to learn very quickly from that and see what works. And that may very well be necessary for some of the things we're talking about with health equity, with workforce, and some of these other ideas that really add health to a community. And then, of course, we will have tribal accelerator programs. We have a government-to-government relationship. And of course, the Indian healthcare providers, the urban Indian health programs will request those same flexibilities. And we work with our partners in the Office of Tribal Affairs within the Healthcare Authority to put those items together and then make sure that we also have some support in that area as well. Let me go ahead and move on. So again, with advancing whole person care, this is where we start getting into, well, how would we do this? So what do we mean by accelerator programs through ACHs? So again, we would like to do some furthering of the clinical integration of behavioral and physical health, provider supports. This is where we would make sure that we're bringing in some capacity building so that we're helping the clinical providers as well as the community-based providers work together. If you look down at that first golden arrow there, so here's some examples that we're thinking of that we may come up with. Again, these are things that we can, develop with you, but the assessment. So it says the healthcare integration assessment. So this is a good example of what could be done in an accelerator program, is that we could actually develop the assessment in one ACH, like we are doing right now in Healthier here in King County, test it out, see what kind of common elements we would have in an assessment, and then say, well, how would we roll this out to the other ACHs? Can we make it work across the board in the same way? Should we tweak it a little bit here or there? But it's one of those things where we can leverage the efficiencies of trying to develop it in one area and then do the coordination and technical assistance as we roll it out. So that's a good example of what we can do in year 6 to continue with that assessment. And so year 6 can bridge into the renewal that we're talking about. This could be done in a lot of different areas. And it doesn't have to be in one area. It could be done in different areas, and then we could share how things are going. The second one is the capacity building and the coaching for providers. So this is the transformational elements that we want to make sure that we receive federal funding, and so that we can continue to support everything that happened in the practice coaching. I think the things that you were used to in the early days of the waiver. And we see that there's the next step to take here. There is still capacity building that can occur. There's help with providers, especially if providers have to, figure out how do I work with these accelerator programs? How do I respond to the incentives? How can I go about doing this? And this is where we are hoping the Healthcare Authority will again take a lead with developing the waiver, but then if the waiver is approved, with implementing it and working with ACHs in that role that you play as neutral conveners, but bringing the players of the system closer together, yourselves, the community partners, clinical partners, the managed care organizations. And we feel like that can be done with the neutral convening, but we have to bring some dollars to it. So that there's still capacity building to be done. And the waiver can bring, the renewal of the waiver can bring some dollars to that. And then of course, the last one there is on workforce. This has been an area that's been very difficult to, I think, get an overall strategy. I think there's pockets of success throughout the state, good stories about what's happened well here and there, but the gaps are just too big. And of course, the pandemic exacerbated the gaps, as I mentioned. And we just feel again that some funding through the waiver and some strategic ideas about how to implement this either statewide or regionally. We're open to either way, as long as we're working with the partners and coming up with a way to do this. Of course, the other thing that's difficult about workforce is that we have to look at the transformations we want to put in place. And then of course, workforce is a support for that. So we're always trying to tailor the workforce strategy behind what we're trying to do transformationally in the capacity building. But I still think we can work that so that we have a strategy, we make adjustments as we go, and then we share information across the state on what works and what doesn't. And then at the bottom there, we do talk a little bit about community information exchange. Again, this really is a information technology support for community-based care coordination, for workforce. But we feel like we probably cannot achieve a lot of the goals that we'd like to unless there is a better way of digitally knitting together all of the activities that we do. Even at the ACH level, but possibly regionally and statewide, we'd sure like to see the whole state in some way knit together the activities that go on with community information exchange. And we are requesting funding for that as well, actually in multiple ways. So we'll keep requesting that until we get it. And then if we could move on, and I'll try. So some of the ideas that we have here, this is where it starts getting into sort of Medicaid minutia, but to implement the accelerator programs through the ACHs, we would like to focus on the readiness. And then here's the first bullet there. We're talking about the formalized partnerships in the communities. And one of the ideas that we have is that if we go down to the accelerator programs, the third bullet there talks about community-based care coordination hub. That hub would be supported by a community information exchange. We see the hub as a key area for transformation and help with practice transformation, but we don't want the hub to be a bottleneck. We want it, matter of fact, to have many ports of entry and easy entry, and then kick out with solutions. And then we want to look at evidence-based interventions for those health-related social needs. Again, there's plenty of evidence about what works. And again, we want to make sure that there's flexibility at the local level to do that. And then of course, testing the investments and the constructs to see what works. And then of course, other innovative partnerships and agreements. So this gets down into, some of the weeds about when CMS asks us, well, what do you want to do? How are you going to do it? This is the how part. So this is where we would want to talk about, here's how a social accelerator program would be developed. And then the next slide is, so the payment innovations, this is where CMS, the Medicaid program, offers us some ways to do this. And this is where it gets to, we need to start figuring out how we would do this so that when we are done with the 5-year renewal at the end of 2027, things have a place to sit. There is a way to keep this going, and we have sustainability. And these programs are called in lieu of services and value-added services. If I could, without, again, getting into all the minutiae of how we are able to contract with MCOs and to do things in a fee-for-service environment, these just give us buckets to put those accelerator program activities into, so that they can continue and so that we have a way of paying for them in the future. At the same time, we can have the funding from the waiver pay for them in the 5 years of the renewal. But the accelerator programs lay the groundwork and will build the capacity, and then we can provide those through the in lieu of services and the value-added services. The reason that they are there is that even though those are incredibly wonderful mechanisms to use, we need to ask CMS for some mechanisms or some flexibilities on how to implement them, because we still think there are barriers to implementing in lieu of services and value-added services that get in the way of being able to use them. So we can do that for the 5 years of the renewal, make those investments, see how they work, and then ask to continue that as we go forward. So on the next slide, so the accelerator programs and the funding streams, again, just trying to recap here, whole person care, health equity, or health related services. Again, we do this through the statewide capacity development. Again, we see a lot of community engagement and convening, strategic planning and analytics. We think that we can come up with a statewide whole person care that takes off from what we've started with. So we can assess integration. We can see what is working and what is not, what things we want to still try, and then have practice transformation. And then with the health related services and support, so we do that through the regional accelerator programs. So this will be the big pitch that we will make to CMS to continue the renewal. And then on the next slide, I think when we meet now with our partners and talk about how we would do this, there has to be some kind of a construct. And so as we get into some of these details, this is what we've been talking about with Allison and her peers, is that we will probably have to have something like 3 to 5 focus areas on how to do health-related social supports and health equity work. We would, because in some way we have to structure this and organize it so that it's easy to roll out. The key, though, again, is within those focus areas is to have a lot of flexibility. But if we can do this in a way that says, well, there are certain social supports that all you have to do is tap those and move forward because they've been pre-approved through the renewal process, then that's terrific. It still doesn't mean that's the only list that you can choose from. We're just trying to make it easy to move out on the things that have evidence that show that they bring value and they help the health of the community. So the funding pool, we would incentivize, of course, implementation of what we're doing, the infrastructure needs and the initial payment and services. Of course, a lot of that's based on readiness. So in different parts of the state, we may be more ready to do certain things than others. So we're happy to move out there. And then in other parts of the state, there may be readiness on additional items to do. And so we would be happy to move out with those as well. We don't have to move out at the same pace with everything that we're doing. We do, on the third bullet there, we do need to have lead organizations, again, within the community for the funding, and we envision the ACH as being those lead organizations doing neutral convening for the accelerator program. And then in this case, the ACH, the lead organization, would not be expected to actually retain the funds or provide the services, but you would be the organization that would do the local distribution and make sure that there is a way to engage the partners, and so that we can make those gains in health equity and health related social supports. I think with the one big exception being community-based care coordination, which may need to be either housed or contracted in a closer fashion. This time around, MCOs will be critical partners because we're using those in lieu of services and value-based services buckets to implement some of these items. But the insurance entities are not expected to receive incentive payments on this because we're already using the items that are within their rating process, and this will be again a big benefit there. But then we'd be able to talk about sustainability with all the partners at the end of this whole renewal. And then HCA will have to play a key role in bringing all the players together. So this would be the managed care organizations, yourself, in collaboration and planning on regional opportunities. Again, like we talked about, with having the flexibility to achieve statewide goals and to make sure that we can say, yes, we are spreading these things across, we are spreading good ideas, implementing them across the state. They may not be implemented the same way in every area, and that doesn't really matter because we're achieving results in every area. So, and I think we're getting close to the end here. So just in terms of timeline again, BY 5 and 6, please think of those as what we're doing today, but we're attempting, especially with that extra year, we got that 6th year extension year. We want to start building a bridge to what we're doing in the renewal. And then in BY 7 and 8, we would sure like to move out very quickly with those health related services and supports funded by the renewal, and have address those payment and policy barriers. Again, I would like to see, we would really hope to have this done very early in year 7, so we're moving out. And the same thing with the value added services and in lieu of services formalized and incentivized. Again, we don't need to do it the same way, or we don't need to start in the same place throughout the state. And then we'd have to have some of these Medicaid financing mechanisms implemented. And again, this is where we can make the best of those systems that we already have, the in lieu of services and value added services, but bring forward some funding and capacity building from the renewal. And then really concentrate on spread and scale, across the regions, and then have the renewal payments phase out over time, because again, we would like to find a way to have all this in place. That's the idea behind these waivers, is to fit them into the full system at the end. And then the next slide, please. I'm going to ask you to go ahead and go to the next slide as well. The reason I want to just go through these very quickly is that a lot of times people ask, well, what kind of things would you do? And I'd like to just leave these slides with you. I mean, these are the kinds of things we're noticing. If we wanted to go back again to the previous slide, we just want to leave people with a sense that there are ideas, there are things that are being done. They're being done in our state. There's housing, there's food and nutrition, transportation, care coordination. We see these things being done around Washington state. They have been these items have been submitted as waivers in other states, California, North Carolina. And again, these are not to constrain us, but they just show that there are big possibilities here to do things that help with the health of a community. And so we're not starting from scratch. We're open to new ideas. What we'd like to do is, at least these things that are working, that have shown some evidence, is to make it very easy just to tap these things and move forward. And then there might be a process, there would be a process for other ideas as well. So if we could move forward and then move forward again, I'd just like to leave these with you. So the MCO plan alignment. So we're going to encourage the MCOs to work with us on in lieu of services and value added services. We've talked about the potential list. We believe that one of the ways that we can do that, working with the MCOs, is to have discussions about the incentives that we can bring forward. There would be shared savings, of course, and then of course we need to get some flexibilities for the MCO benefit, and so that we can work with them on doing it. And actually, we're just beginning these conversations with the MCOs. So we've had extensive conversations with the ACHs over the last 2 months, because of course we had to find out that all of this stuff would have some traction with all of you before we could even roll it out and start talking about the financing and possibilities with the managed care organizations. So again, I think if we can go to the next slide, I think that's where we're at. I think I have a couple slides in there as possible appendix and such, but Allison, at the end there, it's a little tough with some of the Medicaid stuff.
I actually pulled out the appendix for you, Michael, because I thought there was probably enough content here for the level of where things were at without going into too much added detail in that way. So I'm sure you love it when people edit your presentation and don't tell you till you're in your presentation. But we're very nimble around here at BHT.
Well, I love it. Thank you. Thank you.
Does anybody have any questions for Michael?
Hey, Pam, this is Sharon. I have lots of questions. Michael, this is a fabulous presentation. I really appreciate the way you and the Healthcare Authority are kind of laying this out and scoping this renewal. So I don't want to hog the questions, but a real simple first question is, do you have an idea yet at this point in time about what the dollars that would be available under this 5-year renewal?
Sharon, first of all, nice to see you and thank you. That's a spot on question. Yes, we do. And this is where we are trapped by the budget process and asked not to really speak of our decision packages at this time, going to the Office of Financial Management. So let me, just for your benefit, Allison's benefit, and others, I think we will have funding to pull this off. It will not be as large as the waiver, the first year waiver, and that was very intentional. And I apologize that I can't comment on it yet. The budget will be developed and out by the end of this month, September, and then we'll have full discussion. But I do want you to know that myself, the people I work with, my boss, Michelle Needham, we have shared our intended funding with our partners at the Office of Financial Management, and we didn't get any big pushback on the number that we shared with them. And that's what we were looking for a first meeting. And then I very much look forward to being able to share the funding figures with the executive directors of the ACHs and others when we can do that right after the budget is submitted.
Totally understandable. Thank you.
Hey, Allison, do you think maybe you could quit sharing your screen just so I can see people who have questions?
You bet. Erin, can you do that? Thank you.
There we go. Does anybody else have a question they'd like to ask of Michael?
I have a question, Pam. This is Zeke.
Hi, Zeke.
Hi. Hi, Michael. I'm Zeke Smith, at the Empire Health Foundation here in the region. And thank you for sharing the presentation today. Really great to see. We haven't met yet, but I've heard good stuff about you, and it was played out well in the presentation, so appreciate that. I had 2 quick comments. One, I loved seeing I guess 3. One, just feels like there's been good either momentum shift or just more visibility into how you all are thinking about the emphasis on the ACH work, the MTP work in this renewal conversation that you have with CMS, and I just love seeing that. So appreciate that, because I think there's a lot there. 2, that idea of really thinking about this 6th year as a transitional year, as an opportunity to really build into what this new framework might be, feels really great. And having had a little bit of experience working in the context of waiver renewal processes, I like that transparency in terms of really engaging community partners in the process. And then 3, the place where I had some experiences over the last 7 years in Oregon, working on the transformation and waiver renewal process. And I love to see not just Oregon, but other states in terms of kind of helping to instigate thinking about what might happen moving forward. And, one of the things that I really like about the model here in Washington is that the ACHs really have a different opportunity in terms of community governance and community engagement, frankly, than in Oregon, where you've got that kind of built into the CCOs or MCOs as a part of the structure. On the flip side, it means that it's a little harder, I think, here to really engage those MCOs in an effective way, because you're kind of playing on their margins more than really pushing them into the fold. So I love to see that slide where you really talked about how, ultimately, how do you cultivate an environment where the MCOs have the same incentive to be at the table. So appreciated that. My question for you is, I would think that the new administration really creates some space and some opportunity for some of what you've talked about here in a way that wouldn't have been possible before. I can say that, you didn't say that, but in particular, I think the emphasis on health equity and in grounding that in a tangible way in the work would have been fallen on pretty deaf ears before. And I think that the ways in which the ACH is in this role around community governance, around shifting the work to be not just about what's happening in a clinic, but also really about how the community is an effective partner in that process, is probably opened up in a different way. And so I'm just wondering if you're, and if you want to take the 5th, I get it. But if you have any thoughts about how, or if you even have begun to see in terms of the work that you all are doing with CMS, where the new administration is opening up some opportunity for leaning even deeper into some of those values that are kind of embedded in important ways in both the last waiver, but really can, I think, shine as you move forward in this next renewal process.
Zeke, very nice to meet you. And yes, couple comments, and then I'll answer. But first is I'm a member of a very good team. Second is we actually do have conversations with the ACH executive directors about coordinated care organizations, CCOs down in Oregon, and the way that they are organized, and then the way we have more of a ACH MCO construct up here. And just to put a pin on that is that, yes, there are pros and cons to both. And that's why I don't think we see any reason to leave the construct that we have, because yeah, we might gain some things, but we would lose some things. And then I feel like we're just moving around the deck chairs of the ship. We might as well let's accept the construct we have and work with it and make it work. Because we do talk to Oregon, and matter of fact, the health-related services and supports, the HRSS acronym you saw that you probably recognize, we stole that straight from the Oregon proposal that they submitted. It encompasses all the things we want to do with ACHs and with MCOs. It's a construct, it works. It seems to be being well received by CMS. And so we thought, why not? Let's just use it and go forward. But it does mean that we have to put things into the MCO ACH world that we're in here. So I do see that there are, first of all, with the new federal administration, yes, we have been opened up. They have told us directly in meetings to try some things, and been very open with us to be ambitious. And that was their words in the last time we met. And then also, I think many of you may have seen that CMS, well, I should say the CMS leaders, Chiquita Brooks LaSure and her team put out a very nice vision statement. What was it, about 2 weeks ago? And we were thrilled to see that just all of it lined up with what we've been working on and talking about with the ACHs. So I think that I do see the places where we can do something good. And if I could maybe expand on your question a little bit and then turn it into challenges. And so I think that, again, the challenge that you'll hear from us is that we have to propose to CMS that we think we can actually make more ground than what we've been doing with the current waiver. And the way that we're going to be doing that, of course, is to talk about some of those technical elements. Again, I apologize for all the Medicaid minutia in there. But we will have to sell this idea that we can come up with a common way to work across the state and then leave flexibilities at the community level, because that's the only way that you succeed, but then a willingness to be measured and to see how we can work together and to use those measurements, not, you know, so much for, like I say, a thumbs up, thumbs down, but to learn from it and move on. And then I think our other big challenge that I haven't talked about as much is that the Washington State Legislature does authorize our funding. Now, as much as CMS approves the waiver renewal, our legislature comes first and they have to authorize the funding. And the only way they authorize the funding is we have to make a convincing case that we're not just tossing policy ideas around. We believe that we know, we've done our research, we've talked with people, we believe this will make a difference with community health. And we need to make that case and make it very strongly and convincingly and listen to the legislature and be sure that we're not missing anything, that we're taking seriously critiques that they might have. And then make sure that we arrange a proposal that will work for them, because that is our first test, is really internally and within our state. And it's funny that I don't mention it that much in the presentation, because that's where my head is 99% of the time right now. I'm not even thinking about CMS. So it's and I think that actually we probably get better critiques because our legislative body knows what's going on. They see the successes, they see the places like workforce, for example, where we need to do better. And so we're fully concentrating on making that case, and that's what I'd like to do before the end of the year, and then get into the, and really you have to make that case before session starts, because session goes so fast. There's no more time to convince somebody that you know what you're doing. There's only time to hopefully remind them that you've come up with something good and something worth spending money on. So even though it's federal money, our Washington State Legislature approves or has must authorize the funding.
Pam, can I just jump in real quick?
Yeah, Julie, go ahead.
So Julie Hohenkamp with the Spokane Community Action Agency. So I very much work on the social determinants side of whole person health. And I would just say, I think data continues to be our big challenge and our link to our behavioral health and physical health providers. And until we get that bridge holistically built, you're not going to be able to make that case. It's just too much of a lag right now. And I know you know that. So thank you for getting that in there and keep pushing on it. It's sure a big challenge, but I really would love to hear just a couple more minutes on the social investment models you're thinking about. We run a big CDFI here in town. And I guess we're trying to figure out kind of the fiscal side of the sustainability of this model as well. So if you wouldn't mind sharing some thoughts on that, I appreciate it.
Yeah, nice to meet you, Julie. Help me. CDFI is a
community development financial institution. So basically a nonprofit bank that does a lot of lending, like Craft 3 and some others.
Oh, your question has all kinds of clarity now.
Yeah.
Yeah. So it'll be tough for me to answer directly, and it's not a put off, please, but it's the idea that we need to make a case that to the legislature and CMS that we have the partners to work with, and we have a very good sense of what is needed in the communities. Then I think, what we also have to convince CMS and the legislature of is that we know how to pull this off, and we know how to work with communities. And so you'll hear a lot more from us about working closer with MCOs and ACHs and all the players in the market. The list that I provided there, again, is things that we recognize that work really well within Washington State. And also they've been given some flexibilities in other states, Julie. So we feel like those are good starting places. I think the one thing, and I might be being a bit repetitive here or maybe not getting the gist of your question, so please let me know. But I think what we'd like to do is within the framework of the in lieu of services and the value added services, we would like to say, let's just take transportation, for example. Here's transportation. It is evidence-based. We know it helps, it works, it helps knit together all of the things that somebody who's in need is, just can't connect with without help. And you can just jump in and do this one. It's kind of like being pre-approved. But then we want to make sure that there's flexibility because this is a 5-year renewal and other ideas will come up just as good as those things on the list. And we want to have a swift way to evaluate those and then go forward. So I think what CMS is going to hear from many of the states is let us go forward with pre-approved lists. Give us some flexibilities to work with the MCOs and it's all on the rating side, Julie. So I don't like to get into it too much, but it's really where the flexibilities need to occur. So there aren't any barriers there to have disincentives for MCOs. So we're trying to remove the disincentives for MCOs to participate with ACHs. But just to recap, would love to have a pre-approved list, the easy way to get at these things so that they just move out in the accelerator programs early on. You don't have to spend 2-3 years developing it. Flexibility for new ideas that you guys will come up with your ACHs so we can evaluate them quickly and put into place. And then with the MCOs, this is where the key parts of the waiver we'll have to talk about. Here are the rating flexibilities we'd like for MCOs so that there aren't so many barriers to working with the MCOs. And we have to start early on that because we want to make sure that when this renewal is done, you don't really get to ask for a second renewal. We want to have this stuff embedded within the state. So,
Come in.
Yeah. So Julie, am I at least getting at some of the things you hope to hear about?
Yeah, I think a little bit, and I'm happy to grab your email address offline too from Allison and maybe drop you a separate email as well. Thanks.
Yeah, thank you. And that actually gave me a chance to probably bring some other people into the discussion who could probably, talk more one-to-one on your stuff and what you probably know more about than I do.
Okay, thank you.
Yeah.